Sorry, guys. I had a power out there, and I thought my was plugged in. I hadn't flipped the switch, so sorry. That was my fault. So I was sorry. I was trying to explain about ischemic and hemorrhagic stroke. So if you've done a CT scan, there's no bleed, you're suspecting it's an ischemic stroke lacking blood supply, then you need to decide if you're in the 4-hour window. Now, current guidelines in the UK support a 4-hour window. So if that patient is presented within 4 hours, then provided there are no contraindications, they can be given thrombolysis treatment. This is basically IV treatment to clot bust, to basically break up the clot in the brain so that you're limiting the damage to the surrounding tissue, where the penumbra of the brain is what you're trying to protect, essentially. But there are very strict criteria for thrombolysis, and there are a lot of contraindications. What we mean by contraindications is essentially factors that make a certain treatment or management plan unsafe for that patient. And the way we split contraindications is into absolute and relative. So absolute contraindications means if that factor is present, you absolutely must not use that treatment. It's against guidelines and it's against safe practice in medicine. However, there are also relative contraindications. This means these factors might mean that treatment shouldn't proceed, but not necessarily. And there is an element of clinical judgment and deciding on how important that factor is in determining the safety of a particular treatment. So, for example, absolute contraindications to thrombolysis include a previous history of a hemorrhagic stroke, previous sort of a known brain tumor, brain injury or brain surgery in the last few months, or history of stroke is another important factor. Or active bleeding or any bleeding disorder, because all of these factors would mean if you were to give thrombolysis, the risks are too great. You're more likely to cause an additional bleed on the brain on top of potentially an ischemic stroke, which it puts the patient's morbidity and mortality at high risk, essentially. Relative contraindications might be things like being on anticoagulant therapy, but then, that's not always a contraindication. It depends how sort of much effect that anticoagulation therapy is having. Pregnancy, TI, there's a few other relative factors like uncontrolled hypertension as well as a relative factor. So we basically have a checklist to make sure the patient doesn't have any absolute contraindications. If they don't, then they can proceed with clot busting thrombolysis. And then the next question is whether that patient is eligible for a mechanical thrombectomy. So this is essentially where you are going into that vessel and trying to take out the clot. So it has to be done by neurosurgeons only. So that patient has to be transferred to a neurosurgical center if they are eligible for mechanical thrombectomy. And it has to be done usually within 12 hours of presenting with a stroke, so it's quite a short period of time window that you have, and obviously not all patients are suited to it. But if anyone has a stroke, this is why we have the FAST campaign. Okay, I'm sure you've all heard of that. You have to act quickly because time is brain, and we really do mean that. If patients present after 4 hours, then under current guidelines, you can't thrombolyze. Your best treatment is sort of antiplatelet therapy with aspirin, for example, for the next 4 weeks, high dose. There are trials going on to see if you can extend that 4-hour window. So, for example, there's a wake-up stroke trial going on at the moment. So if you wake up with a stroke, you've no idea when that stroke actually happened while that patient was asleep. So there are trials to trial thrombolysis in that patient group as well, and beyond the 4 hours. But it's not in current guideline practice. That's sort of your optimal treatment for stroke. And then the other part of stroke is kind of trying to work out why that stroke has happened. So thinking about risk factors, things like blood pressure, smoking, a big factor, cholesterol, diabetes, testing HbA1c, testing, we would test all of these routinely in a stroke patient and then optimize them, because it's about secondary prevention. Okay, so they've had a stroke, you now want to limit subsequent issues, with the risk factors that have caused that stroke. Primary prevention is the idea that you're trying to prevent that stroke in the first place. So that would be, for example, the 40-year-old health check, getting on top of blood pressure, stopping smoking early to prevent it in the first place. So that's really important as well. And then other investigations you might do, because sometimes you need to work out why that blockage has happened in the brain's vasculature. Why have you got a clot there? Is it like atherosclerosis, so essentially a plaque formation in the vessel because of blood pressure, high blood pressure, cholesterol, smoking, etc.? Or do they have, for example, that these big, if you feel your pulse don't feel both pulses in your neck because you could faint. But if you feel one side of the pulse in your neck, that's a massive artery. Those are your carotid arteries, internal carotids. Going up to supply all the blood supply to the brain. What can happen over time is these arteries can become stenosed, essentially, and once you have like a 50% stenosis, then you start to think about doing a procedure called a carotid endarterectomy, where you surgically put a slit, small slit in the neck, and then clear out that vessel, essentially, because if you have a plaque in that vessel, it's because of the high blood pressure, it's risk of throwing off clots to the brain that can lead to stroke. So that's why you do an ultrasound scan to determine the stenosis, the blockage of that pipework, essentially. And then you can also do cardiac investigations, so an echocardiogram, a functional scan of the heart and how it's working, how it's pumping. The heart is essentially a pump. Cardiologists wouldn't like me for that, but it's the pump, and your vessels are your pipe work. And if you have a blockage in that system, or your pump isn't working properly, then you run into problems. So you sometimes need to analyze if you've got clots being thrown off by the heart, and a cause for that can be what we talked about, in this case, atrial fibrillation. So this is where so you've got 4 chambers of the heart. You've got the 2 atria, right and left, and 2 ventricles. The atria are your basically, that's where because the electrical activity of the heart is all integral. It's a completely innate unit to the heart. Yes, it's controlled by the brain for speed and heart rate, but it's an innate system to the heart. And the area at which that electrical activity begins is in this sinoatrial node in the atria, the right atrium. So you can have so if you feel your heartbeat, it's a lub-dub, type when you listen with a stethoscope. But you can have irregular heartbeat, and that's essentially, it can be because of atrial fibrillation if it's irregular. So it's completely random beating. And the problem with that random beating is you're more at risk of throwing off clots. And there's a risk every year for anyone with atrial fibrillation of developing a stroke, much higher than the general population. And therefore, for patients who have long-standing atrial fibrillation, we need to anticoagulate them. So what we mean by that is we need to lower the risk of forming a clot in the first place. And how we do this currently is either with warfarin or with newer agents called direct oral anticoagulants. So warfarin is like rat poison, essentially, and it's a very old drug. It's still very commonly used, and there's some cases in which only warfarin's your only option. For example, in valve valvular heart disease, and valve replacements. But more and more we're moving to the newer agents, and it's very much, when you're talking about anticoagulation with a patient, it's about risk, it's about benefit. The risks are, yes, they could develop a bleed on the brain. Yes, they could have a massive GI hemorrhage, gastrointestinal bleed out. They could have perirectal bleeding. They're more at risk of bleeding, essentially. But you're preventing them from having a stroke, which is a massive, an awful disease, with huge ramifications. So it's all about, as it with anything in medicine, it's about risk benefit analysis. Just to finish, I'm a little bit conscious of time. One of the questions is about NG feeding tubes, which is nasogastric feeding tubes. So it is as awful as it sounds. It's essentially a tube that goes from your nose, goes down your gullet into your stomach, sits in your stomach, and then allows you to feed without the risk of aspirating that feed. So if you have a weak swallow, sometimes that food is at risk of going into the trachea and into the lungs, and that would lead to an aspiration pneumonia, a collection of infection. So you sometimes in our stroke patients, you assume their swallow is weak. You assess the swallow, if it's safe to swallow or not. If it's not, then you can give them techniques to try and improve that swallow. But it certainly takes a period of time for the patient. And that's why another very important member of the team in stroke therapy are the speech and language therapists. So these are the specialists in speech and swallow, and they have a lot of fancy techniques for assessing the strength of a swallow. So very, very important people in the stroke multidisciplinary team. Okay, so that completes my PBL section of the study guide for this month. So the next couple of bits aren't too much longer for you. The next part is a situational judgment test. So this was a professionalism question. So it's, for example, a colleague, you're on a busy rotation, you can tell she's a bit upset, she's not been herself, and suddenly she sort of breaks down in front of you. It's all become too much for her. And the question was, what are the 3 most appropriate actions to take in a situation like this? Now, of these options, some are more appropriate than others, some are entirely inappropriate. But really, like any human being in that situation, what you should do is just sit her down and go through what the issues are. Is it a personal issue? Is it a work issue? Just be that human in that situation, as somebody to talk to, because you would want that if you were in that situation. So that's the first thing to do, is a listening ear. And then the second thing to do is to try and address the work issue, because in this case it is actually a work issue and she's struggling to cope with pressure from seniors and jobs. So the only way that you're going to be able to solve her issues is to address them head on. And one way of doing that is communicating with her senior staff. So, she really should go to her registrar, because, registrars are seniors, they've been there and they've done that. They know what you're going through. But sometimes they need to know if you're struggling, or if you're, if something's happened that has upset you. A registrar is a good person to go to, because they know how to handle it. They have the wisdom, they have the expertise. So actually, that is an actual solution to this problem, discussing it with her registrar and then seeing how that problem can be solved. Another important thing, as a foundation doctor, we all have educational and clinical supervisors. These are consultants whose job is to be there if we need them, and if we do have problems with our training or with our clinical teams that we're working with, we must go and discuss that, because it might be other people are having that issue. It might be, partly, are you struggling with something that you need help with? It's all about, in these professional case scenarios, it's about actively trying to deal with the problem, not sitting on the fence about it. Taking annual leave, okay, yes, a lot of us might well do that, but it doesn't actually deal with the problem. And once you finish your annual leave, it's going to be 10 times harder to go back to work because you've been putting it off for that period of time. So actually, most of these scenarios, you need to take an active approach to the problem and try and solve it. So that was the SJT case for this month. And then the ethical case for this month was, I hope you get quite an interesting one. So it's about a patient who had a severe hypoglycemic episode, which it means it had multiple episodes like this, which meant that he's not able to drive under the law. And the GMC have actually more recently produced proper guidelines on this, and to explain what you should do in that situation. Because so in this case, I was going to talk to you a little bit about confidentiality and what we mean by that, and then specifically what the GMC guidelines are around driving and advising your patient. So confidentiality essentially means keeping things private or secret, not disclosing them. It is to be confidential. Now, as a medical professional, it is a legal and an ethical requirement that you maintain confidentiality, and it is assumed that you should maintain confidentiality, but it is not absolute. So there are very specific cases when you are obliged as a doctor to break confidentiality. And I'm going to go through these instances with you now, basically. So the first might be, so if you imagine a patient in a hospital environment, there's going to be a lot of teams involved, and you might want to, for example, talk to a cardiologist about a patient on a stroke ward. So a patient, obviously that is disclosing a patient's information, but that other team are directly related to that patient's personal care while they're in hospital. So that patient will have consented to you to be able to disclose that information to another team in the hospital. Okay, a team that are directly related to that patient's care. So that's where a patient consents. Then there's also explicit consent. So a patient writing out to say, I am happy for my information to be disclosed in, for example, a research trial or an educational session, a teaching session for medical students. You need to get consent from a patient. So a patient saying, I'm happy for you to do that explicitly, you need it in writing by law, particularly for research. It's very, very strict guidelines for research in patients. So that's a second reason why you can disclose. A third reason is, we talked last time about patients lacking capacity. So if in patients who lack capacity, they might not be able to consent to you disclosing their information, but if it's of overall benefit, so if you are liaising with other direct team members, then if it's in the benefit of the patient, then it is appropriate to disclose within reason. A fourth reason for disclosure or breaching confidentiality might be that it's required by law. So, for example, by a court of law, if you're called to in a coroner's case, for example, in that instance, you are obliged to discuss details about that patient and about that case. But the rule in all of this is you have to anonymize as much as is reasonably possible, and you have a duty to be handling patients' information responsibly and respectfully, and that means minimizing your contact with patients' personal information. Do you need their name and their address and their phone number? Probably not. A patient number is probably more than enough. Usually we say 2 identifiers is ideal, but you have a duty to maintain, and it's all about GDPR, which I'm sure you're all familiar with at the moment, going round. But it's a massive obligation as doctors to ensure that. And then the fifth reason for disclosing information is it might be justified in the public interest. So an example might be, not only in this case of the driving, but also if a patient or somebody who is HIV positive, who has admitted to, for example, sexual intercourse with multiple other people, if they are HIV positive, you might well in that case have a duty to disclose that patient's confidentiality and ask other people to be tested for those infectious diseases, for example. And it's not just sexual diseases, it's any sort of infectious disease. You may, but it is breaking confidentiality. You know, you're telling other people that there's a problem that needs to be addressed. So it has to be justified in the public interest if that's the case, so that it's serious crime or serious risk from infectious diseases. Okay, so those are the 5 instances according to the General Medical Council when you can disclose information. Okay, but a general rule is if you're going to disclose information, you should seek the consent of the patient and or tell the patient that you're going to disclose it. And you should do this with it in every instance. The only instance you might not do that is if it jeopardized the safety of that patient, for example, in criminal proceedings or whatnot. Now these dealing with confidentiality is can be quite challenging as a junior doctor. So for example, I had a patient who basically was known to be an an intravenous drug user, and had left the ward with a cannula. In situ, like not told staff that the patient was leaving. Now this was a massive worry for us because we were worried that this is a route of infection, a route of potentially access for IV drugs, and we were principally concerned about the patient. So we tried to ring the patient and couldn't get hold of the patient. So then we rang the patient's next of kin, and couldn't get through either. But obviously you can't disclose to the patient's next of kin what the issue is. You simply have to say, we need to talk to that patient. You have to be thinking all the time, does that information need to be divulged? Is it appropriate? Do I have consent to divulge that information? And it's the same with families. Families will hound you for information, and you've always got to go back to the patient, ask the patient if they're happy for you to disclose, and ideally talk to the patient and their family together so that you're all on the same page. That is really important. That mobile phones are also a big challenge for junior doctors. We will get family members ringing us asking for information about a loved one. But how do you know who that person is on the other end of the phone? You don't. You have no idea who they are. So actually, in those instances, you have to say, I'm really sorry, I can't give you any information over the phone. If you want to come in, I will talk to you with the patient and yourselves. So there is a lot of challenges, and I think you always have to be very aware of confidentiality. It is a basic right, and it is integral to our practice as doctors, is that patients trust in us as health professionals to guard and protect their information. And we have a lot of responsibility with that, but it is our duty as a doctor to do that. And therefore, you always have to be thinking, is it appropriate that I share this information? Who am I sharing it to? Do I have the consent of my patient? Okay, so in this case where you've got a man who's legally not allowed to drive, and the doctor, the consultant, informed the patient of this, told the patient it is your legal duty to inform the DVLA. Okay, so you've put that onus on the patient, and then obviously you've documented that conversation in the notes, medical notes. But then the consultant or the GP sees that patient driving around. They're driving around as a taxi driver, okay? So they've gone against what you've told them. They shouldn't legally be driving because of their health, and they are putting people at risk. What if they were to have a seizure at the wheel, for example, because of a hypo episode? Does what they're doing put the public at risk of harm or death? So in this instance, what the GMC would recommend you do is make contact with that patient, bring them into clinic, try and persuade them to stop driving, and persuade them to inform the DVLA. You want the patient to you don't want to break confidentiality if you don't have to. You want to encourage the patient to do it for themselves. If, however, you cannot persuade the patient to inform the DVLA, or if the patient continues to drive and you see them again, then if you've done everything you can and you're really at the last point, then you need to think about disclosing and breaching confidentiality to the DVLA, the Driving Vehicle License Agency. If you are going to do that, you should make every possible effort to inform the patient that you are now obliged to inform the DVLA. You should try and get their consent for disclosing that information. If they don't give you consent, identify the reasons why not. And then if there's nothing you can do, that patient refuses to stop driving and won't inform, that's when you are obliged legally to disclose. But you can see the number of steps that you have gone through to give that patient the opportunity and to not break confidentiality in this instance. And that is so important. And these guidelines from the General Medical Council were asked for by doctors because it's such an impossible situation at times. You really feel like you are breaking the trust of your patient before you, who trusts you to keep all of their information safe. But sometimes you have to act in the public interest, as in this case. And this is where very challenging ethical cases like this require very essentially excellent documentation in the notes. Every conversation, every piece of advice that you've given, how you've sought consent, how you've and you've informed the patient that you need to disclose, because it could be that patient tries to sue you for breaking confidentiality. But if you've ticked the boxes, if you've done everything, then there is no ground to stand on. You've fulfilled your professional duty. And the thing is, with very challenging cases like this, that is what we have. There is a GMC helpline, and there is an MDU or MPS helpline. These are your medical defense unions, medical protection societies. We have to have insurance as doctors, minimum insurance. And if we have a concern or an issue that we need to raise and we don't know how to deal with it, then the best thing to do is perhaps talk with a colleague about it, about what they would do and what they would recommend. But equally, you can remain anonymous in these helplines if you wish to. But there are avenues for information if you're struggling to know what to do. Okay. So that completes everything for me from the medical side of the April webinar. I hope it was helpful for you. I hope you've learned a thing or two. Stroke is a really fascinating subject, so I hope you enjoyed it. Now I'm going to finish now the medical stream. I'm going to hand over to my colleagues now. Sharon, Dr. Uppal, our VP for dentistry, is going to do a webinar, and then our VP for veterinary medicine has pre-recorded hers, so it's going to be accessible to you on the Medic Mentor channel. I just want to say, thank you for your time. Thank you so much for joining us on these sessions. I really hope they're useful for you. They might even be useful when you start medical school to sort of go back through. And certainly with the ethical scenarios, just make sure, I would say to you all, look at the GMC website, the General Medical Council. That is our professional guidance body for doctors. If, how we should act is all on the GMC. They have guidelines for everything. So if you become familiar with that, even at this stage, it will show through in your interviews, and you will be head and shoulders above the rest. I promise you that, because students do the interviews and the ethical sections of the interviews relatively quite poorly. So if you are already familiar with GMC guidelines, you're well on your way. So I wish you all the very best. I know it's a very busy time for you all with exams. So make sure you get your heads down for the next few weeks. I wish you all the very best with your exams for year 13s. It's going to be a big summer for you, a daunting summer. For year 12s, just do your best with your exams. It gives you a good shot for your predicted grades. And I'm more than happy for you to contact me at any point. I'd love to hear from you. I'm keen to know how you're doing and any questions you have. So the best email for me at the moment is vpeducation@medicmentor.org. So I'd love to hear from you. So thank you for your time, and I wish you all the very best. Thank you. Good night.